Hi everybody, my name is Tessa. I'm one of the pharmacy critical care residents. Today I'll be giving a talk on the pharmacology of agents that you see commonly on your unit. So the objective of this presentation is to review the pharmacology of sedatives, neuromuscular blockers, and anti-epileptics. Starting off with our sedatives, mechanistically these work through central nervous system depression. And they decrease neuron firing in the brain through increasing inhibitory neurotransmitter effect through GABA or decreasing excitatory neurotransmitter effect through glutamate. Starting off with our opioid agonists, these are fentanyl or hydromorphone. You also might have heard it referred to as Dilaudid. Mechanistically, these stimulate mu-opioid receptors to cause CNS depression. Pros of this class is it has analgesic effects. For dosing, fentanyl you can see here, it's an IV infusion titrated to Rascol. So this is 12.5 to 500 mics per hour IV. Hydromorphone is 0.2 to 8 milligrams per hour. Also note you can bolus from the bag or vials if more rapid sedation is required. And max concentrate is available if the patient is fluid restricted. Just note that the patients don't need central access to have max concentrate bags, but unfortunately these are not able to be loaded in Pyxis and will need to be received from central pharmacy. For adverse reactions, these can cause hypotension or constipation. Just some precautions is hydromorphone can accumulate in renal impairment, so we might avoid this agent in patients that have renal dysfunction. For our GABA agonists, this is our propofol, aka dipiravan, or midazolam, also referred to as Versed. Starting off with propofol, this is a good agent because it has anticonvulsant effects. It also can decrease intracranial pressure. It also is good for neurochecks because it is rapid on, rapid off in its effect. For dosing, it's also an IV infusion titrated to Rascol. So generally it's 5 to 50 mics per kilogram per minute. Use actual body weight when programming this agent into the pump. Higher rates of up to 200 mics per kilogram per minute may be necessary in refractory status epilepticus. For adverse reactions, the one that we're most worried about with this agent is hypotension, but it also can cause bradycardia. We'll be monitoring for hypertriglyceridemia, which can cause pancreatitis, and of course propofol infusion syndrome, which is a very rare side effect of this agent, but can happen in patients that are on high doses of this for a long period of time. For precautions, this can accumulate in hepatic impairment. For midazolam, aka Versed, this is also, since it works through GABA, it has anticonvulsant effects. For dosing, it's IV infusion titrated to Rascol, anywhere from 1 to 15 milligrams per hour. Also can be bolus from the pump or vials if more rapid sedation is required. For adverse reactions, the main one we're worried about for this one is delirium, as it has been associated with higher rates of ICU delirium when used. To a lesser extent, hypotension. Generally, we'll use this agent in patients that are hypotensive because it is the most hemodynamically stable of our sedatives. For precautions, just caution that it might accumulate in renal and hepatic impairment. Last sedative that we'll be talking about is dexmedetomidine, also known as its brand name Precedex. Mechanistically, this agent stimulates alpha-2 receptors to decrease sympathetic stimulation. Pros is it does have some analgesic effects. It also provides lighter sedation. So this is our RASS 0 to -1. Not the best agent for patients who are requiring a lower RASS goal of -5. It also is good for neurochecks because it is rapid on and rapid off. For dosing, it's IV infusion titrated to Rascol, anywhere from 0.2 to 1.5 mics per kilogram per hour. Generally, we use actual body weight, but if this patient is obese, you can consider using adjusted body weight instead. For adverse reactions, you're worried about bradycardia and hypotension. For precautions, it is hepatically eliminated, so caution in hepatic impairment. Use beyond 48 hours requires approval by specific attendings at our institution. Also, a note, if you're using it for more than 48 hours, there is that risk of withdrawal. So we can use clonidine, which is a very similar agent, to help titrate off of this drip without causing any withdrawal effects. The next class we'll be talking about is our neuromuscular blockers. So these work in the motor end plate, so they act on acetylcholine receptors to result in paralysis. So in the image here on the right is just a visual of the motor end plate. So you can see here in the box that I circled the cholinergic receptor. This is where these agents act to cause paralysis. Starting off with our first agent, which is our depolarizing agent, this is succinylcholine. This agent binds to acetylcholine receptors and actually activates them, which initially can cause muscle contraction, but quickly will put it into a refractory state and not be able to contract. For dosing for this agent, it is 1 to 1.5 milligrams per kilogram IV. This is a rapid IV bolus. Generally, we use this agent for rapid sequence intubation or in the OR. We do not use this agent as an infusion. Since you are initially activating muscle contraction, you can imagine there's a lot of contraindications of this agent. So any patients that have a history or a family history of malignant hyperthermia, we're going to want to avoid this agent. Also, patients who are hyperkalemic, have muscular disorders like muscular dystrophy or MS, crush injuries, severe burns, and rhabdomyolysis. This agent is not a good choice for those patients. For precautions, there's caution in renal insufficiency. Next is our more common class that you're going to see are non-depolarizing agents. So this is citracurium, also known as Nimbex. Also have rocuronium and vecuronium that are a part of this class. Mechanistically, they're the opposite of our depolarizing agent. So essentially, it blocks the acetylcholine receptors, so acetylcholine cannot bind in order to cause paralysis. For dosing, you can see here that citracurium and vecuronium are IV infusions. Generally, you're going to titrate this to train a 4 goal. Initially, you start off with an IV bolus followed by a 2 to 10 milligram per hour infusion. In contrast to rocuronium, at our institution, we do not use this as an infusion. We just use it as an IV bolus, generally for rapid sequence intubation. So this is 1 mg per kg, and we'll use this in the acute phase instead of as a long-term infusion. For adverse reactions, honestly, there's minimal overall. These are pretty well-tolerated agents. Precautions in renal insufficiency, except citracurium, which can be used in renal insufficiency. The last class that we're going to be discussing is our anti-epileptics. Mechanistically, these decrease neuron firing through modulation of ion channels or neurotransmitters. As you can see here on the picture on the right, there's many different anti-epileptics and many places in which these agents work to decrease neuron firing. We're going to be going through some of the more common ones that you're going to be seeing. Starting off with our GABA agonists, we have our benzodiazepines and barbiturates. For our benzodiazepines, these are short and fast-acting, so therefore they're the treatment of choice for active seizure. Barbiturates are a little bit longer acting, so they can be used as maintenance treatment. Generally, we don't use benzodiazepines for maintenance treatment, but barbiturates can also be used with active seizures as well. For dosing, we have lorazepam is given as a 4 milligram IV bolus. Diazepam is a 10 milligram IV bolus. For midazolam, it's first line in our patients that do not have IV access yet. That's given as a 10 mg per kg IM injection. It also is a good agent for our patients that require sedation or have refractory status epilepticus because it can be given as an IV infusion. That's dosed as 0.1 to 0.15 mg per kg IV load followed by the IV infusion. This infusion is titrated not by nursing but by an epilepsy attending based on EEG reading. For our barbiturate dosing, for phenobarbital, we have 15 to 20 mg per kg IV bolus that's used in acute seizures or status epilepticus. It also can be used orally for maintenance treatment at a dose of 60 to 200 mg per day. We'll titrate the maintenance dose based on drug level monitoring. For primidone, maintenance treatment dosing is 150 to 1500 milligrams per day. And then we have pentobarbital, which can be used in refractory status epilepticus. This is generally used last 9 because it puts the patient into what's called a pentobarb coma. This is given as a 10 mg per kg IV load, followed by the 5 mg per kg per hour IV infusion for 3 hours. After that 3-hour time point, you reduce the rate to 1 to 4 mg per kg per hour. And again, this agent is not titrated by nursing, it's titrated by the epilepsy attending based on EEG readings. The next group of agents that we have are sodium channel blockers. So this is phenytoin and phospheniton, and then carbamazepine and oxcarbazepine. For phenytoin and phospheniton, phenytoin can be given IV or PO, and generally is given as a 15 mg per kg load, and then given as a 5 mg per kilogram per day. Phospheniton is an IV-only agent that is dosed in phenytoin equivalents. So generally there's also an IV load, which is 10 to 20 milligram phenytoin equivalents per kilogram load, and then a 4 to 7 milligram per kilogram per day in phenytoin equivalents after that. For adverse reactions, can cause arrhythmias, which is why we have a max administration rate of these agents. For the max administration rate of phenytoin, it's 50 milligrams per minute. And for phospheniton, it's a little bit faster. You can give a max of 150 milligrams of phenytoin equivalent per minute. It also can cause extravasation, aka purple glove syndrome, and also can cause severe skin reactions, including DRESS. For drug-drug interactions, these agents may increase metabolism of certain medications. For carbamazepine and oxcarbazepine, these are oral agents that we use as maintenance treatment rather than for acute seizures. For carbamazepine, it's 2 to 20 milligrams per kilogram per day orally, and oxcarbazepine is 300 to 240 milligrams per day orally. These can cause severe skin reactions as well, including Stevens-Johnson syndrome and TENS. Also can cause myelosuppression, and more commonly, hyponatremia. For drug-drug interactions, they also may increase the metabolism of certain medications. And also for note, for phenytoin and carbamazepine, we commonly draw drug levels to be able to further monitor treatment, which would be a trough prior to the next dose when these agents are at steady state. For valproic acid, also called Devalproex or Depakote, which is the brand name, this is also a sodium channel blocker, but it also can increase GABA availability as well. It's given IV or PO, so during active seizures you can bolus this at 20 to 40 milligrams per kilogram. Just note that there's a max IV rate of 10 milligrams per kilogram per minute. For maintenance dosing, we have 10 to 60 mg per kg per day PO. There's many oral formulations available, including liquid, sprinkle capsules, extended or delayed release capsules as well. They all have slightly different dosing frequencies, so just be aware of that. For adverse reactions, this can cause hepatotoxicity, also can cause birth defects and what to avoid in patients who are trying to become pregnant. For drug-drug interactions, these agents may inhibit metabolism of certain medications. The last agent we'll be talking about today is levetiracetam, also known as Keppra. Mechanistically, we're not sure exactly how this agent works. It acts on calcium channels and also may facilitate GABA transmission. For dosing, this also can be given IV or PO. For active seizures, you can give 1,000 to 4,500 milligrams as an IV bolus. For maintenance dosing, 500 to 1,500 milligrams PO, Q12 hours. Just to note, there is renal dose adjustments, and it is 1-to-1 IV to PO conversion. So in our patients that don't have oral access, you can give IV for their maintenance dose as well. For administration, it can be given undiluted as an IV push up to 1,500 milligrams, and you're going to bolus each 500 milligrams over 1 minute. For adverse reactions, it's pretty minimal overall, but can cause agitation. For drug-drug interactions, again, it's minimal. This is a really great agent if patients are on other medications that interact with our other anti-epileptics. That's all I have for you today. If you have any questions, feel free to reach out to me via email. You can also talk to your floor pharmacist, Nadine, who helped me make this presentation as well. Thank you.